Welcome everyone to today's webinar. I am Emma Beamer with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, I want to thank today's webinar sponsor, ASCOA. ASCOA specializes in turning surgical centers into profit centers, and we are looking forward to hearing from two of their experts. Mr. Jeff Peo is the Chief Development Officer for ASCOA. He joined the company in 2005 as a financial analyst and most recently worked as a Vice President of Acquisitions and Development. During his tenure, he has been responsible for the development of highly profitable ASCs that have generated over $250 million in revenue. He is a regular contributor to industry publications and a speaker at industry conferences. Prior to joining ASCOA, Mr. Peo ran a knowledge management and information technology consulting division for a Fortune 100 company. Jeff graduated from Brigham Young University with a degree in manufacturing engineering. He lives in Salt Lake City, Utah with his wife and their 3 children. Mr. Jason Beam is Senior Vice President of Operations with over 19 years of experience in the ASC setting, including OR nurse, clinical director, certified first assistant, OR manager, and administrator. Prior to ASCOA, he was Regional Vice President of Operations of multiple facilities for USPI. From 2008 to 2012, Mr. Beam was co-founder and president of Implant Solutions, LLC, providing ASCs with focused management on orthopedic and spine surgical implant purchasing, inventory, and billing services. Mr. Beam has a BSN from the University of Tennessee at Martin and received his CASC in 2003. Jeff, I'll now turn the floor over to you.
Thank you very much. We're grateful for all those who are attending today and hope that there's some value for you in the things that we're going to talk about today. As you can see, we put on the screen here our Jason and my email addresses. Please feel free to jot those down and shoot us any questions that you do have, or if you would like to talk to us further about some specific problems that you're having. We'd love to help you if some of the things that we talk about today don't address exactly what it is that you're looking for. Today, we really want this to be helpful to you, that you can take some of the things that we're talking about and implement them into your surgery centers and have ways that you can improve the profitability of your surgery center after listening to this call. When we had you register, we actually had everybody or gave everyone the opportunity to talk about some of the specific things that they were having trouble with or things that they'd like to hear about. And so we took the time to pull all those questions together and looked at the ones that we got the most, and we're going to try to address those questions today. We recognize that we won't be able to get to everything today in the short period of time that we have, and so we'll have a question and answer period afterwards, which you can type those questions in there so that Scott will be able to ask some of those questions to Jason or to myself. And also, if we still don't get to those questions, feel free to email us and ask us those questions. Or we're both going to be at the Becker's meeting in June and love to meet with you in person and talk with you about where you are with your center and things that you're doing. So we're pretty open. One of the things I really love about the surgery center space is that it really is like a family, where everybody's willing to share best practices and things that they're doing to help make themselves more profitable. It's not a cutthroat environment like some other environments I've been in. That's one of the things I really love about the surgery center, the family. And so we are more than willing to share with you some of the things that we've found in running our 80 centers across the country that we've had, and to try and help give you some tips and some advice on things that might help you in your individual center. So that's what we'd like to do today. We're going to cover the biggest areas for improvement that need to be addressed. And again, let's make this something that you're going to take away, something of value for you. And so we'd love your feedback through the question section there on the side. Okay, here's the topics. The biggest things that, according to the people that took the time to respond to us and on the sign up, the biggest things that they would like to see covered. And those were, how do we improve our efficiency? And the other was how to improve our profitability. They broke down basically into those two types of categories. We're going to talk about key areas for efficiency gain. We're going to talk about metrics that you can track to track your efficiency and to have something that's measurable so you can see if you're actually improving or not. And then in the profitability category, we get a lot of questions about case costing, how it is that we do case costing, how do we make it so that it's not so onerous and burdensome, and something that's simple but yet is meaningful still. So we'll talk a lot about case costing. We'll talk about the way to improve some of the top line in your revenue numbers to help achieve profitability, and that's in recruiting new cases. And hopefully if you're recruiting the right cases, it also improves the bottom line there. We'll talk about improving reimbursements and also about improving collections. So those are the main areas that we're going to talk about today. So we'll just get started, jump right in there. And then again, if we're not addressing, or if there's specific questions that we leave out, or a wrinkle that you're not hearing, please feel free to shoot us a question in the question section on the side. One of the things that we, ways to improve our profitability in the surgery center is to make sure that we are recruiting. Recruiting is getting harder and harder. I'm sure that all of you at this point take time to, or one of the things that you're trying to do is to recruit new cases to your center to add that profitability, to add the top level revenue there. We have a philosophy in all of our centers, and that is to ABR, always be recruiting. We always need to make sure that we're talking with our partners in the surgery center to make sure that recruiting is happening, that you're always asking about new people that may be moving into the marketplace, or people that they've been talking to, so that we can find new people to recruit. One of the challenges that you have when you're recruiting is, who do you recruit? Do you recruit new specialties? Do you stay within the specialties that are already there, within your surgery center? And what challenges do those two different approaches take? Let's talk first about recruiting within the same specialties that you already have. One of the things that I hear oftentimes when I go in and talk to surgery centers that are struggling is that they will say, there are opportunities to recruit other doctors within the same specialties that we have, but our doctors don't like those guys because they're competitors, and they don't want to bring them into the surgery center. I can understand that. I can understand that there's that rivalry and that there's hesitancy to bring them in. One of our founders, Dr. Tom Bombardier, when he was very first starting up a surgery center in Massachusetts, they organized, and this was back in the mid-90s, they organized a group of ophthalmologists who were all at the time doing cases in the hospital that were all their rivals. None of them really could stand each other. What they would do is, if they were walking down the same hallway, in the hospital or somewhere else, they would separate to the other ends of the hall and wouldn't even look at each other as they passed. But they were able to recognize and realize that by having this together, this center together, that they could actually have the strength that came from having those additional cases. And they had to view it as, I'm making money off my competitors, and so that's a helpful and beneficial a thing for the surgery center. So one of the keys I would say is to work with your doctors and get those names of people and try to help them understand that it's important to get as many possible cases as you can in the center. And unless there are quality concerns about the care that those people provide, it's absolutely beneficial to have them bring those cases into the center. If you need to add additional specialties, or there are doctors there who are want to come join your center, but you don't have the equipment from there, what you really need to make sure that you're doing when you're adding specialties to your surgery center is that, will they bring enough cases to justify getting the equipment that they need to do those cases? And are your contracts set up so that you can get reimbursed properly for the cases that are coming? If you're adding spine, or if you're adding orthopedics, or if you're adding ENT, those things can be expensive to equip the center. And you start talking about implants or supplies that come in with those, they can be very pricey. And if you're not set up with your contracts to be able to do and bill for those appropriately, then you're going to lose money. So make sure that you're giving the people a trial. Make sure that you're working with the vendors of the equipment that you need to get it as a loaner to come in, and give that person a trial before you offer them ownership, and make sure that you can get reimbursed and that you know what you're being reimbursed for those cases, and make sure that that is going to be successful. Some areas right now to look for new doctors. Oftentimes it's really difficult. There's not a lot of doctors floating around that don't have ownership in surgery centers. One of the ways to look for, or one of the people to look for, are doctors that are coming off their hospital employment. There are a number of doctors that recently, in the last 5 years or so, took employment contracts with hospitals, and they are not very happy about that and are starting to roll off of those contracts. Approach those people as they have a year left or so, and start talking to them about becoming owners in your surgery center as soon as, or users of your surgery center as soon as they are rolling off of their employment contracts. Start to talk to them now, because if you're not going to talk to them, other surgery centers in the marketplace are going to talk to them. So it should be an area for you to look at. Look at new people that are coming out of school, or partners that are coming in, potentially to doctors that are coming into the practices of your partners there, and see if you can start lining them up and giving them a place to do cases and setting up a path to ownership for these doctors. In the end, what you need is to make sure that you're using your resources wisely when it comes to bringing new doctors on. If it does not make financial sense to bring these doctors on, don't bring them on. You need to make sure you're doing a very thorough analysis of what it will cost to bring these doctors on, how many cases they'll bring, what you'll be reimbursed for them, and see if it makes sense financially to bring. Your partners will not be very happy with you if you suggest or recommend that these doctors come in, and it ends up eating away their existing profits. The only reason you bring in new partners is if it makes it better for everybody. So that's one of the ways that we can look at profitability in the surgery center, by recruiting. Jason, are you back on with us?
I'm back on. Is that better?
Oh, it's significantly better. I'm going to back this up a little bit here, and let's get you back to where we were. Okay.
Yeah. Apologize for that. I don't know what's going on.
All you. Go ahead.
All right. Well, I'll just start back from the beginning. So one of the key areas of efficiency that we focus in on is the OR time that's being used in your facility. Too often what we see is cases spread across multiple ORs, and where we really focus in on is compressing or using vertical scheduling and moving those cases into one or two rooms versus multiple operating rooms. This also allows you to able to compress your days that you're open, and not, maybe you only have enough cases to really function in 2 or 3 days out of the week, and you're closed the other 2 days, not having to staff those rooms. Some other areas of efficiency in scheduling is also with staffing and supplies. With staffing, it's all about having the right staff, having staff that's flexible with their hours, having staff that get how an ASC operates. In many markets we face where our staff are hired, they come from existing hospitals, have been in a hospital for a long time, and maybe they just don't quite can keep up or can do what we ask them to do in our ASCs. We run a very tight and efficient surgery centers. From supplies being available, we really want you to have accurate and up-to-date preference cards for our physicians. What you don't want to see, or what's inefficient for you in your OR, is staff having to leave the room, go looking for supplies that weren't pulled for the case. You want everything right there readily available so that you can minimize your time that you're spending in your OR. I want to talk about block utilization. Personally, I'm not a fan of block utilization. It can be a major hindrance to being able to effectively run your ORs. How often are you looking at block time utilization? What policies do you have in place, to evaluate block time utilization? If you're not running currently, a physician's not at least utilizing 80% of that block time, then why do they have it? Typically, we see with block utilization is it's poorly managed. It's not looked at very frequently. For guys like Jeff and our development team who are recruiting new docs, if they come to you and say, I've got this doctor who wants to come in and your OR schedule is full of block time, it makes it very difficult to get any new physicians, any new case volume into the center. And then physicians typically also, when they have block time, they're not sending you your cases over your information until, the day before or not giving us enough time to do what we need to do as far as pre-certifying and authorizing cases to be performed. And do you have a policy in place on what it would take to, for you to open up your another room? This would vary across the board as far as specialties, but all of our facilities have something in place stating that, if it's a GI doctor or if it's an orthopedic doctor or spine doctor, how many cases is it going to require where it makes sense for us to open up that additional room and staff that room and have those cases come in? So you need to know the profitability of your physicians as well by specialty. Next area for efficiency in the ASCs, I'll put inventory in here. Inventory is an area that is very time consuming for our materials managers and in our facilities. We'll talk a little bit here about case costing in just a minute, but it's very important that your inventory is managed appropriately. They hear me say all the time, it's trash in, trash out. It requires a lot of work to keep your inventory up to date and pricing accurate and contract compliance and that type of thing. If you'll spend a lot of time in your case costing or looking at supply costs, if your data that you're getting out of your inventory is not correct, you're going to spend more time investigating and having to look as to why. Stock levels, you want the appropriate amount of stock on the shelf. You don't want to be overstocked. Again, look at your par levels. Do you have par levels in place? And that type of thing. Preference cards and depletions. I already hit a little bit on preference cards as to why they need to be accurate and that type of thing. But also, is your center depleting the inventory on a case-by-case basis? Are they being done? What's your policy on for the depletions for the case that was performed? When does that happen? Does it happen at the end of the case? For me, it's at least by the end of the day, or at least not a couple days out. And then contract compliance. This is one area that is really overlooked and not that can be very costly to the center. But we're seeing, and I want to talk a little bit about new technologies that are out there for you to possibly look at to evaluate that can really streamline the efficiency and the processes for your materials manager. These new technologies allow you to replace the intensive manual workflow with an efficient and automated solution that can lead to saving a bunch of time and money. It allows your materials managers to place orders all at once. It tracks the discrepancies between what was ordered and what was delivered. And it also allows us to stay contract compliant. These technologies will tell you that, hey, this contract's about to expire, or there's an alternative drug or supply that's on contract with your vendor. You need to look at it. And for us, it updates the pricing across the board for all of our facilities. So it literally eliminated the amount of time our materials managers had to spend on the day-to-day operations by almost by half. Which for us, for most of our materials managers, they're scrub techs, and that allows us to now get them back into the rooms. They can pitch in and help. They can scrub cases. An interesting study out there shows that 14% of invoices are inaccurate in some way. That leading to resulting in a 6% overcharge on invoices. For us, I have facilities that have, $3 million in inventory ordered in a year. If we resulted in a 6% overcharge, that could be as much as $180,000. Next one for efficiencies, I want to discuss the business office. First, we have for AR. The biggest inefficiency you can have in your accounts receivable is dealing with denials. Denials are very costly to the center. It requires a lot of work, a lot of follow-up for your staff, and you want to do everything you can to avoid those denials. So it's all about what you do prior to the case being done. Do your work. For the pre-certification and pre-authorization, make sure that your staff's doing those for every single case. Utilize the tools on the payers' websites for services that require pre-certification. You want to call all your payers several days in advance. When pre-certifying or authorizing the procedures to be done in the facility, don't just do the primary code. You want to cover a full range of the CPT codes that are going to be possibly done on that procedure. The biggest, what we see for denials is a procedure gets performed and you bill it and it wasn't pre-certified prior to the case being done. And then look at those implants and those high-cost drug items, if contract allows, to see if those require any additional approvals. Some other efficiencies affecting in the business office, the timeliness of the dictation from your doctors. How much time are you tracking down, calling physicians' offices, looking for the doctor, trying to get them to timely, do the dictation for the operative note. Tracking down needed information from pathology from the doctor's offices. We expect our claims to go out the door 24 hours post-date of service, no later than 48 is our goal. Again, here I want to introduce some new technologies that are out there and available for you. In particular, we're using some mobile app technologies that link into our patient accounting system. This is allowing our physicians to have real-time access to their surgery schedules. The surgeons are able to dictate their H&Ps and op notes, and we have a turnaround time of less than 2 hours of getting those back. That allows us now to get off the coding and get the bill out the door. Surgeons can review their op notes and their H&Ps and electronically sign them. So we're no longer having to track them down. Transcriptions are then automatically sent to our billers and coders and any other referring offices or anywhere else that you're having to stand there at the fax machine or scan and email, making copies of to send it. It's all done automatically. We're able to communicate through this new technology with secure text messaging. It sends alerts to our doctors saying, hey, you operated on this patient yesterday and we still do not have an operative note dictated, or you haven't signed your operative note. And then for us, mostly it allows our administrators or our office managers to track the progress. Just a simple dashboard we can look at every day, and we can see that what's been missing, or H&P is missing for this patient, or the op note's been dictated but it has not been signed. So all this allows us to be much more efficient in our ASCs. See, Jeff went to the next slide. So now I'm going to discuss some metrics for efficiency in the ASC that you can use to measure and benchmark yourself against. Again, AR days, accounts receivable is a very important one to us. This is obviously measuring the amount of time it takes for you once the bill goes out the door, how long it takes you to get paid, to get the cash into the facility. An industry average for this is 40 days. I can tell you SCOA runs at approximately about 30 to 33 days. Now, this metric will vary slightly on your payer mix, how much commercial, how much Medicare that you have in place. You could see a lower AR number if you have a high number of Medicare or federal government payers, because they pay, in a 14 to 21 time day frame. If you have a lot of commercial, we would expect to see that, for us around 33, 34 days for AR. Note that you also, if you see a very low accounts receivable AR days, that could be a red flag for you as well. Like I said earlier, it could be indicative that you have a high Medicare percentage, but for us, it also could mean that our collectors are collecting that money, what's paid to them initially, and then not really working that account anymore. They're just writing off the balances and not not going after the additional money owed to you. So they really got to know their contracts. They really got to know what the right payment's supposed to be, and then do the follow-up. And then obviously you can benchmark your days for this. For us, we have our own sister centers that we can benchmark against. But if you don't, then you can use the ASCA website. You can use the ASCA community and maybe find facilities that are like yours that you should benchmark against. Or I know Becker's has benchmarks out there as well. Another metric or efficiency in the ASC is our turnover time. We really hone in on this for our facilities. An overall good average for you to be looking at for a multi-specialty facility like ours is 10 to 12 minutes. But I'll break that down for you further in case you have more specialties than others. For us, eye and GI, we see average 5-minute turnover time. General and ENT cases, we see on average 12 to 15 minutes. Pain cases, less than 5. Orthopedics, 15 to 18 minutes. Now, what are some of the things that might affect your turnover time? First, as I mentioned before, look at your staffing. Are you staffed appropriately for your cases? Are your staff on board and working as a team? If I have available people that are maybe in another room that are in between cases or waiting on the physician to show up, my expectation is to see them in there helping turn the room over. They're not hanging out in the lounge, and they're not disappearing on us. Anesthesia is a big one for us for turnover time. They've got to be on board with you on being efficient and how to turn those cases over. Is the doctor out there in pre-op seeing the next patient, going through the interview process? Are the blocks being done prior to going to the OR? And of course, the physicians. We don't want to be looking for them, having to track them down. Looking for them in the lounges. Hopefully by the time the doctors come out of the room, gone and talked to the patient's family, walked over to pre-op, talked to the next patient, go and dictate their op note, we're close to being ready for them in the OR. Another metric is late starts. Late starts are detrimental for you. If you're really compressing your schedule and implementing vertical scheduling, you're going to have 3 or 4 different physicians in that room throughout the day. The worst thing you can do is start the day off an hour behind schedule. So why is it happening? It's very hard to change a chronic late doctor. We have I have a 3 strikes and you're out rule, particularly if they're in that prime starting time of 7 a.m. or 7:30 and their first one starting the day off. You've got to develop a workaround, and you've got to work with that physician on why late starts are detrimental to you in the facility. Cancellations, another area where if you're having cancellations the date of service or 1 or 2 days out, it's very inefficient for the facility and very costly. You've already taken the time to pre-certify and authorize and work the accounts and calling and talking to the patients and tracking down information and H&Ps and charts, and probably ordered supplies that you needed for that case. And then if they cancel, then that's not efficient or profitable for the center. What we typically see in our centers is on those days of service or 1 or 2 days out, we want to see less than 1% of our of the volume canceling. And then profitability, some key metrics. I listed a few for you there. Our profit margin goal is 40%. When you're looking at your medical supplies, medical supplies and payroll are the 2 probably most costs in the center that you have the most control over. So a good metric for you to look at and see where you are is medical supplies are around 25% of your net revenue, and your payroll comes in around 28 to 30% of your net revenue. And again, that'll vary on payer mix as well. If you have a higher government payer, you might expect to see that percentage to be a little bit higher versus a good commercial mix. Yeah. So now we're going to talk about some profitability in the ASC. For us, case costing is a key tool for us evaluating our profitability and sharing data with our physicians. We perform this case costing on a monthly basis. We do this on a trailing 3-month full trailing 3-month basis. So in other words, this month we'll be working on February's data. But given us 90 days or a 3 month lag period, it gives you enough ample time to collect the money from the payers so that you have good data to share with your physicians. We do this for every case done in our centers on a monthly basis. So what we do is what we want to look at is the cases performed by that doctor, the amount of time that it takes to do those cases, the supplies and implants that are associated with that specific case, and then an overhead cost that we factor in for the fixed cost of that case. So your overhead cost plus your supply cost will actually equal your total cost of that case. And then we look at what we collected for that case. And then we look to see if it was profitable or not. So a way to calculate your overhead cost per minute is, I'll give you a formula here that you might want to write down. But what you want to do for the month that you're reporting on, so in this case, we were discussing February, we want to run a P&L for that month in accrual basis. I know some probably use cash for their accounting for their centers, but you want to run this report in an accrual basis. You want to take the total operating expenses for that month, and you want to subtract out your supply costs, which include the implants, and then subtract out any interest payments that you might have made on a capital loan or a working capital loan. And then you want to divide that number by the total operating minutes for the month. So what I mean by the total operating minutes for the month is the amount of time the patient spent in the OR. So when they crossed the threshold into the room and then when they came out of the room. This will give you your new operating cost per minute. We take that number. For a SCOA, that number across our facility runs about $18 to $20 per minute. So when you're doing your case costing, when you want to factor in what your overhead costs were for that case, we take that dollar amount, that $18 per minute, and times that by the number of minutes it took for that physician to perform that case. That'll give you your fixed overhead cost for that case. You'll then add in the specific supplies and implants used, and that gives you your total cost. So how do we use this data? We show this data to our physicians every month. I recommend doing it monthly. I know probably a lot of you out there might only meet quarterly or maybe less than that, but I would recommend running this exercise on a monthly basis. This is not something that you can do the day of your meeting or the day before your meeting. This requires you to do it a couple of weeks out, because you're going to find things that need to be looked at or don't look correct to you, like the OR minutes spent on a particular case. If a physician averages 30 and they're in there for 230, that's going to show, a huge overhead cost for that case. The last thing that I want you to do is present bad data. You show this one time to a physician and the data does not look right, you're going to lose your credibility and be able to present case costing and profitability to them. Again, we share this with the doctors monthly. This is their favorite thing to look at. We'll hand it out in our board packet, and it's the first thing everybody goes to when they start looking. They start looking at this because they want to see where they stack up against their peers and where they stack up with the other physicians in the facility.
Jason?
Yeah.
Would you mind repeating the formula? We've had a couple requests for you to repeat it. If you could just repeat it slowly so people could follow that'd be great.
Absolutely. So the formula to calculate your overhead cost per minute, I want you to run a P&L for the month that you're reporting on in an accrual basis. From that P&L, I want you to take your total operating expenses and subtract out supply costs and subtract out any interest payments made on capital loans or working capital. That'll give you your new total operating expense that you will then divide by your total operating minutes for that month. And again, the operating minutes are the amount of time that each case was spent in the OR.
Jason, I'm going to give you just a couple questions on it, as long as we've hit this point right now. Do you do case costing per physician by CPT codes or by top total CPT codes and not by doctor? Do you do it by doctor for CPT codes or not? And then is it for minutes? Is it minutes for patients in the OR or minutes for the surgeon cutting to sewing?
Sure. So the first question is well, let me answer your second one. The minutes in the OR, not cut time. So the minute the patient goes into the OR to when the patient comes out of the OR is what you want to use for your total minutes. And then we do this on a monthly basis. And what we do is, and I think a couple slides from here, I'll be able to show you what our headers look like for our case costing. But we do it for every physician, every case they performed. So yeah, so at the top there, that's the headers that go across. Shows the date of service. It has the patient account number. Here we show the primary CPT code and what the procedure name for that is. But that's not inclusive of all. We won't list all the CPT codes because this report can get very lengthy. If you have, we have facilities with 60, 70 doctors. So we just show them the primary CPT code, but a couple of columns over, you'll see the number of procedures actually performed on the case. So there's, an ENT sinus case, you expect to see 7 or 8 there. Then we show them the OR minutes that it took to perform that case, the supply and implant cost, and then that overhead cost, which is simply your dollar amount per minute that you just did the formula for. That's multiplied by the number of minutes in the OR. And so your supply cost plus overhead cost is your total cost for that case. And then we show them what the bill charges were for the case, and then we showed what we've actually collected. Now, this is not estimated amount. This is not what you expect to collect. This is what we've collected today for that case. And then simply receipts minus total cost will give you a profit or a loss for that case. And then we have a comment section. If per se you only collected half of what you're supposed to, you could comment there that, claims under appeal or, expect another $150 from patient owed or that type of thing. And then below that, what we show here is what we do is then summarize by specialty to kind of give you a different way to look at the data. A lot of times you'll see here, the top one's orthopedics. Orthopedics is always good cases. You can see total collections for those cases performed were at the top. But then you look at total profit. They weren't the most profitable of all the specialties. So it's just a different way to look at it.
Thank you. That's helpful, Jason. Let me let you get back to your presentation. I didn't want to interrupt, but I know people had some specific questions on what you've gone through on the formula. So thank you very much. I'll let you get back to the presentation.
Sure. So Jeff, if you'll back up one slide. Yep, right there. So here are some examples of how we've used case costing or how you can use it effectively in your center by sharing this information with your physicians. The first example there is we had a pain physician that really was not profitable in the surgery center, and pain's one of those specialties for us that typically always is a good specialty for us and very profitable. When looking at the case costing, we looked at that the supply cost looked a little high as compared to others. Digging in further, the first thing we wanted to look at was the inventory. Was the supplies being allocated to that physician correct? Was the staff doing the right job of not just putting maybe everything that was on the preference card into the cost of that case, but what truly was actually used for that case? In this particular case, they were. But when we looked further, we saw a drug that seemed very high. So when we dug down a little bit further, we learned that the drug was on contract, but there was a missing LOC that could be signed with the distributor. So by signing that LOC, we were able to drop the cost from $78 to $6, which then, lo and behold, the physician was back being profitable on his cases. The next case study there was some ophthalmology. We had a group of 8 ophthalmologists, not all in the same practices, performing in one of our centers. And when looking at case costing and looking at the time, they were coming in at, some of them as high as 50, 60 minutes per case. On average, they were coming in at 46 minutes per case. And what we were able to do is get this group of doctors together and start the conversation of how can we, get better at this. And a lot of physicians will listen to other physicians way before they'll listen to us. But they were able to work together, and by just simply looking at, they were able to modify phaco settings on their for their phaco. We opened up their packs. We showed the packs to what everybody was using. We had wastage on our packs that were, because 3 of the doctors never used this and 4 doctors only used that. We were able to streamline our packs to get them more to the point where everybody was using the same stuff. And then, of course, you have the 1 or 2 or 3 items that you have to add for particular physicians. But we were able to streamline those costs of those packs and not have any wastage. And then they were able to basically agree on 1 or 2 different IOLs where we were bringing in 4 or 5, which enabled us to go back to our vendor and get better pricing on our IOLs. And then the next one was where a particular orthopedic surgeon in one of our facilities was always profitable, always looked good, but he had a couple of partners or other physicians in there that when we were just specifically looking at rotator cuff repairs, we were noticing that their supply costs were always so much higher than this one particular physician. This one physician took it upon himself to work with the other physicians. He actually volunteered his time and came into the center, and they were actually able to try a different technique. He was able to show them the technique that he was using for the rotator cuff repairs, and then eliminated. We had one guy using 4 and 5 and 6 anchors per shoulder, down to an average of like 2. So we saw the cost drop significantly there, and they were still able to use their anchor of choice. Yeah.
Jason, just a quick question here on these case costing examples. How much are we talking about in real dollar savings for each of these little examples that we're talking about? Like, how many cases was this pain physician doing? How much did these different examples actually save the center?
Yeah, for the pain physician, he was doing 50, 60 cases a month in the facility. So you could just take the cost difference of that drug and, multiply it by 50 or 60. I can tell you in particular to contract compliance, an example that I can give you is just by us looking at contract compliance or LLCs or the appropriate tier levels. We just evaluated 17 supply items at one of our facilities, and just by getting into contract compliance and getting the right LOC signed, we picked up an additional $18,000 annual savings just by looking at. That's why it's so important, and there's technologies out there now that can keep you more on par with that. Look at the ophthalmologist. Reducing this particular center, if I remember correctly, was running at about $22, $23 a minute for overhead costs. If you reduce their operating time from 46 to 21, you can do the math right there on how much savings that's going to present to the facility.
Thank you.
And then the orthopedic one, rotator, everybody anchors out there, you're paying $350, $400, $500 a piece for those things. If you can reduce it from 4 or 5 a case down to 2, you've dropped the price $1,000. Okay. Moving on. Jeff, you already did your slide. So let's talk about profitability in the ASCs as in regards to reimbursements. Contracts with your payers, very difficult, something that always requires lots of work. For us, what we see too often is accepting a bad contract too early. We come into facilities and they accept the first contract that was offered to them, and it's not a good contract. These negotiations take lots of time. Can take, there's contracts that we negotiate can take over a year to 2 years. Something else that, from looking at from a reimbursement standpoint, out of network versus in network. That's a numbers game, but for a SCOA, we've pretty much moved totally to an in-network model. But as you know, when you open up a facility, you're going to be out of network with just about all your payers. You're not going to have those contracts in place. So you have to really look at the numbers game and the revenue stream, because you're doing fewer cases out of network with much higher reimbursement. And then you have to evaluate, all right, if we go in network with that payer, what does that mean to us as far as how many patients we're going to have to do at a much lower reimbursement to equal that amount that we were doing in an out of network basis. And at some point those lines will cross and it will make sense to go in network with that payer. But that requires a lot of due diligence on your half and a lot of data collecting from your physicians and the offices to understand really how many inpatient or in contract patients are available to you. The first point there, being paid correctly. You got to know your contracts. You got to understand that what your expected reimbursement is supposed to be, and then are those contracts loaded into your system? Carve outs when negotiating with the payers and for reimbursement. We really push hard for our carve outs. What do you got to have to successfully get the carve outs? You got to do your homework and you got to know your data. For us, we look at our top procedures that are performed. The most expensive procedures are going to be performed, and that's what we push to get the carve-outs. Same thing for implants. We really push for our contracts to have a carve-out or a separate reimbursement for our implants. A lot of payers are resistant to that, but you got to have your data and you got to know what you spend or what you're losing because you're not able to get implant reimbursement. Billing and tracking of implants, that's a big one for me and for us because, most of our billers are not clinical. So what process do you have in place for tracking the implants when they get used in your facility? Is that information making it back to the business office for that biller to know that I've got these implants that I need to bill for that case? What system do you have in place and what tracking mechanism are you able to verify that is happening? And I put in our vendor negotiation. Obviously, we want to get the best price for our implants. And I know there's many vendors on this call as well. But, I think the most important thing you can do is build a good relationship with that vendor. Oftentimes, I find that vendors don't understand how we're paid, ASCs are paid versus hospital reimbursement or HOPD, reimbursement. Explain those differences with your vendor when you're meeting with them. Obviously, the best choice is be able to get your physicians to agree on one source or, one type implant. But, in real world, that's very difficult to do, and that's not an easy thing to accomplish. So involve your physicians. I find it very useful when I got my top orthopedic doc in the room with me when I'm sitting across the table from a vendor talking about pricing on particular anchors. The physicians need, if you're doing appropriate case costing and you've educated your physicians on what things cost, they're always shocked at how much this stuff is. And then I think one of the biggest things overlooked in negotiating with a vendor or things are what I call the accessories, those supply items that are directly related to implanting that implant. Those are usually disposable. They're very expensive. I'm talking about the suture passers and the, special cannulated drill bits or, all the widgets and gadgets that go with an implant. Those can be as much as 35% of the cost of the total cost of the case. Those come right out of your bottom line because they're not billable to the payer. And so don't forget about those accessories and things when you're negotiating with your vendors. Yeah.
Hey, Jason, we've got just a couple minutes left. I know there's some questions in here. So if we can go through this slide, fairly quickly and then time over to Scott, that'd be great.
Sure. So profitability and collections, for us, again, accounts receivable, one of the biggest things you can be looking at and should be looking at. It's the money coming in the door. So AR protocol, do you have one? Do you have that process in place that's a step-by-step for your staff on how to follow up on claims? One thing for us, we have very specific steps in place for what we call action dates for our collectors on what they need to do when they've called upon a claim. If they've called upon a claim and it says it's in motion, they call that claim back in 7 days. Our claims are touched multiple times during a month. So if they're not doing that, they've got to start. And then document what's being discussed in your system so that person like myself or your administrator, they should be able to go in there and see everything that's happened with that account and the processes and the steps that's been taken to get you self-paid. Insurance verification, co-insurance deductibles. This is obviously a huge bucket of money that we see in our AR that keeps growing for us. Patient responsibility with today is very, very high. What we do, or what we recommend, is doing all that communication up front. When you're calculating your insurance, co-insurance, patient deductible, estimating what it's going to be for the number of procedures that might be performed on that case, call that patient ahead of time and talk to them about what the expectation is on the date of service. Tell them what they're going to owe. One of the biggest mistakes I see is people offering up payment plans right away. I don't recommend that. It's sort of the last result if you're going to lose the case, or they just simply cannot do it. What we recommend is getting at least 50% of your money up front and collecting the remaining of the balance in 30 days. There's companies also out there that you can use, like Care Credit and Greenway, that shifts more of the responsibility over to their, or getting them to pay it on their own credit card. Timeliness of billing, like I said, we want to see our billings going out the door 1 to 2 days post date of service. And again, on the follow-up with the staff, collections is key for your center. How many FTEs do you have dedicated to collecting the money? We recommend, if you're doing 350 cases or more and you have a reasonably controlled AR, 2 full-time collectors doing that. If you have AR that's up there, greater than 40 days and you need to really bring that down, I would recommend adding another collector to the staff. And then cross-train your staff in your business office so that you don't have the lags when somebody goes on vacation or calls out sick. You got somebody else that can step right in and work the collections for you. And then audit. So who's looking at this? And for us, our administrators, is it the business office manager? You got to be going into your accounts receivable and looking for those trends and things with a particular payer so that you can cut them off short. Documentation is key, and like I said, you should be able to go in there and read it like a story on everything that's been done with that patient, and they got to be looking at it. Jeff?
Jason, I've got a number of questions from the audience. Are you ready to start digging into those?
Sure.
Great. So let me start with sort of working backwards. Do you ever recommend dropping a payer when you just can't get a good carve out or good pricing and just going out of network? Do you ever get to the spot where you recommend going out of network because you just can't get a good contract with a payer?
Yes, we've certainly done that, but like I said, it really boils down to what it's going to mean to you. How many patients with out of network benefits are you still going to be able to see, and is that enough revenue being paid at that higher expense? Is that revenue still going to exceed you where you are today if you're contracted with a payer and the number of patients that you're seeing? But we have dropped contracts and gone out of network. And a lot of times that's a motive for them to, come to the table and, the payer comes back to you and says, okay, let's get this going.
Just again, very quickly.
It's not a decision to be made lightly, though, Scott. I mean, that's you need to make sure you're looking at that from a financial aspect, and in depth, for sure.
And the basic assessment is in network times what you're getting paid, what revenues that would generate, versus out of network, knowing you might lose some cases, times what that would generate, and having to calculate whether you'll actually get paid out of network. Jason, let me know if I expressed that right. Somebody had a question about how you make that financial assessment.
That's right.
Great. Let me ask you, the next question is, in computing cost per case, when you compare metrics of percentage of revenues for labor, do you include wages only, or do you include all items under the GL account, workers' comp, PTO, consulting, also a percentage of net revenue on medical supplies, et cetera? And Jason, rephrase it if you need me to.
No, that's right. So for staffing costs that's captured in the overhead expense or from your P&L, everything is in that bucket. Everything that you spend for payroll is calculated in that fixed overhead cost per minute. the reason we take out drugs and supplies is because, you know, those are the invoices that were entered for that month. They're not specific to the actual cases that were performed in the center.
Got it. And a couple other questions, and I encourage the audience, any questions you have. How do you measure block utilization time? How do you measure that? When do you tell a doctor you can no longer have block time? How do you look at those issues?
Right. So block utilization, you know, if I'm not seeing a physician utilizing at least 80% of that block, and that's the amount of time that you've blocked out for that day, and the amount of and then the total operating time that he spent in the OR. So it's not necessarily the number of cases, but it's actual utilization minutes of the OR compared to what you blocked out for the schedule.
Great. There's a number of questions about how do you work with some of your physicians who don't perform and so forth. Let me try this question. Somebody has said that they found when managing vendor contracts and letters of credit, it'd be a bit overwhelming. Any tips to manage this better, sort of LOCs and vendor contracts? Any thoughts on that?
Yeah, you know, in managing your inventory and contract compliance, you know, that's where we've really looked at the newer technologies that are out there available. We work with a particular vendor that's came through our distributor, but it monitors and tracks all the contracts. It notifies us when a contract's going to expire. But it takes a lot of due diligence from your materials manager to know how to navigate if you're using a GPO, using your distributor, on how to navigate in their system and find what contracts are available, what LOCs are available for the particular item.
And there's another question you said you used a mobile app for communication dictation. Can you tell us the name of that again?
Sure. There's a couple of vendors out there. With a particular vendor that we work with is Command Health through Source Medical or SIS, but there's vendors that do the same. Surgical Notes is one. One Medical Passport is one.
So a few different ones that you guys use and have had comfort with. I mean, SCO has been one of the best in the business in turning around centers, and it's been so for a long time. Of these different issues, Jeff mentioned always be recruiting. You, I've heard, spent a lot of time over the years on case costing. You know, just any thoughts on why you've been so successful at turning around centers? And what are the 2 or 3 most important things that you guys bring to the table, Jason? Is it recruiting? Is it this cost assessment per case, the discipline amongst your physicians? What really helps you guys be so successful?
Sure. So it's all the above, Jeff, or Scott. But from us, one of the top things, I think when I discussed talking about schedule compression, I think that's probably the most inefficient area that we see when we come into a troublesome center really struggling financially. It's the misuse of their OR time and not that vertical compression of their schedule, and being open 5 days a week and staffed for those 5 days a week when really they only justify having enough cases to be open, 2 days a week.
And that's still a big. Go ahead. I'm sorry.
No, Scott. Scott, let me just jump in here. I think really, none of the things or the concepts that we've talked about here today, although we've, are repeating some of the equations so that people can use them. None of these things are really, really difficult. It's just the discipline of doing them on a regular basis and making sure you utilize the information that you get. And, that's really one of the keys to our success at ASCO is the discipline to make sure that we're following these easy key steps and teaching the doctors what this data actually means, and then making decisions based on it.
A lot of it's just the regular discipline, not necessarily rocket science, but Jeff, Jason, your regular discipline and approaching this. And that's what I've always seen with you folks. That's sort of that's a lot of how you characterize it.
Absolutely. Yeah.
Okay. And then on top of it, the compression of scheduling. That's something that's always been a problem, and it's a hard political thing to deal with at first until people get their hands around it. But that really can keep the same amount of revenues and cut costs by 23%.
Correct.
But great discipline to do it. But let me do this. I've got to wrap up so we don't lose our audience, and so I don't keep Jason and Jeff on longer than they have time to stay on. Jeff and Jason, there's some other follow-up questions that you see, and hopefully you guys will be able to follow up with some of those. I want to thank you for your time. It was just I appreciate very much the highly informational webinar with virtually no sales pitch at all for ASCOA. So I'll just say one thing or two. One, ASCOA is one of the best companies in the surgery center business, has been for a long time, really experts in making the most of centers that are struggling and turning them into profitable centers. You guys have had a great track record. If it can be turned around, you guys are probably about as good as anybody or the best company to do it. Jeff or Jason, phone numbers or email addresses that people could reach you guys at?
Absolutely. Let me, we've got up on the screen right now our email addresses. You can certainly contact us there. I'll give you my cell phone number right now, 781-635-5750. And also we'll be at the Becker's meeting. If you're going to be at the Becker's meeting, even if you don't have a specific question, we'd love for you to stop by our booth and just say hi and tell us you talk to us and or listen to us ramble on for an hour on the webinar. We'd love just to visit with you a little bit and hear how you're doing. Jason, do you want to give your cell number?
Sure. It's 781-812-4662.
Great. I want to thank you very much. I know the webinar was great because of the people that listened in. Literally 95% stayed on until the very end of it, which means you provided highly informative information. And Jason, I appreciate you switching phones to just make it clearer for the audience. Thank you very much. Jeff, is there anything you wanted to say to finish up, or are you okay?
I was just going to say that we did get a list of some of the questions. I know that we didn't get answers to all of them, and please feel free to reach out to us. We'll try to follow up with you too. If we see some questions that are on here that didn't get answered, we'll try to follow up with you as well. So,
thank you so much. We'll talk to you guys shortly. And again, thank you, and I'll see you in June at the Spine, Orthopedic, and Pain Management Driven ASC Conference, plus the Future of Spine. Thank you very much, Jeff and Jason. Just fabulous.
Thank
you guys.
Thank you.